Hi there, welcome back. This is part 3 of drugs for thromboembolic disorders. This is the last part of this lecture. All right, so let's move on to our next group of drugs, the antiplatelet drugs. The good thing about this class is that you guys are already pretty familiar with these drugs, even if you don't know it yet. We talked quite a bit about aspirin, and I've actually talked about clopidogrel or Plavix a couple times throughout the course. So you may remember these drugs inhibit platelet aggregation, and I mentioned that these drugs are good for conditions where arterial thrombosis is of concern. So let's start with aspirin. So the first antiplatelet agent that we'll talk about is aspirin. Aspirin irreversibly inhibits both the COX-1 and the COX-2 enzyme. We're going to talk a lot more about inhibitors of the COX enzyme when we talk about pain management in a couple weeks. For now, let's focus on aspirin's ability to reduce platelet aggregation. And it does that because of that irreversible inhibition of both the COX-1 and COX-2 enzyme. That essentially creates an inhibition for the life of the platelet. And so thromboxane activity, which is a mediator in platelet aggregation, is inhibited for the life of the platelet, and prostacyclin is inhibited for several hours. So this inhibition lasts the life of the platelet, which is about 8 days. And that's why aspirin can be used as for reduction in platelet aggregation. Unlike other NSAIDs, aspirin is an NSAID. Unlike other NSAIDs like ibuprofen or naproxen, those are reversible inhibitors. So aspirin is irreversible and is able to inhibit that activity for the life of the platelet, and that's why we use it as an antiplatelet agent. So there are lots of therapeutic uses. In this lecture, we're just talking about the antiplatelet agent use. We'll talk more about other uses when we talk about pain management. So focusing on the antiplatelet agent use, these drugs can be used for prevention of ischemic strokes and TIAs because of their antiplatelet activity, as well as unstable angina, acute MI, during and after coronary stenting, as well as primary and secondary prevention of MI. The dose that's used is 81 milligrams. That's considered a low dose or baby aspirin strength. 3 to 125 milligrams is sometimes used immediately after an MI, meaning like the first day or maybe the second day, but then the patient should be converted over to 81 milligrams orally per day. And that's because the platelet aggregation, the antiplatelet effects at 81 and 325 milligrams are the same, but there's increased risk of bleeding with using a higher dose. So 81 is just as effective with potentially fewer adverse effects. So 81 milligrams per day is what is recommended. Now, aspirin has some serious adverse effects. It can cause GI bleeding, can cause hemorrhagic stroke, among other side effects. And sometimes these can even occur at low doses. They're much less likely, but sometimes they do occur at lower doses. All right, so let's move on to Plavix or clopidogrel. This drug works by blocking P2Y ADP receptors on the platelet surface, and that prevents ADP-stimulated platelet aggregation. That's a mouthful, right? Don't worry, you don't need to know all that. I just included that for completeness sake. And I know some of you like to know kind of the nitty-gritty and why things happen. So by blocking that receptor, that is going to actually prevent platelet aggregation, and that's why these drugs are effective antiplatelet agents. The prototype is clopidogrel or Plavix. There are a couple others in this drug class that are on the market. By far the one I expect you guys will see is Plavix. Therapeutic use, I already mentioned, this is an antiplatelet drug. It can be used most of the time. This drug is used for prevention of coronary stent stenosis. So the patient has had a stent put in one or more vessels. That stent is at high risk for rethrombosis, especially early on, the first 6 months, the first year. And so these drugs, their primary use is for preventing that rethrombosis of those stented arteries. It can also be used for secondary prevention of MI. Drug-drug interactions, the one that I've mentioned to you guys before that I think you guys should know is the interaction with proton pump inhibitors. And so, so these drugs can interact with omeprazole, and it has to do with the fact that this drug is a prodrug. Clopidogrel is a prodrug, and it requires enzymatic conversion to its active form. And it's activated by the 2C19 enzyme. And so PPIs inhibit that enzyme. And so because of that, the drug can't effectively be activated. Drugs that promote bleeding can also be a problem with these drugs. So, obviously, if this drug is used in conjunction with heparin or aspirin or other drugs, the risk of bleeding increases. Now, with that said, this drug is frequently used with some of those other drugs that I just mentioned. All right, so this drug is given orally, and like with all of our other anticoagulants and antiplatelet agents, this drug can cause bleeding. And so that's the primary concern with using this medication. Unfortunately, there's no specific antidote or reversal agent available. So if the patient does experience bleeding, interventions such as transfusions or even medications like prothrombin concentrate complex or factor 7A recombinant, these are other drugs that can be used. But the bottom line, what you guys need to know is that there is no specific antidote like there is for some of our other anticoagulants. The nursing implications, obviously educating patients on signs and symptoms of bleeding or thrombosis, making sure that they recognize that they shouldn't use proton pump inhibitors with this medication. And then, of course, telling everyone, right? So tell everyone you're on this medication because it could change management of other conditions or management of this condition. All right, and so finally, let's talk about thrombolytics. Our prototype thrombolytic is Alteplase. The thrombolytics, you might remember, I said these are also called fibrinolytics, and that's because they promote the lysis of fibrin, which causes the dissolution of a thrombus. All right, so our prototype drug is Alteplase. In clinical practice, you'll hear people call this TPA. The brand name is Activase or Cathflow Activase. Again, these are other names that people will commonly refer to this medication in clinical practice. As I mentioned, it mimics the action of naturally occurring human TPA, and this results in the digestion of fibrin. Therapeutic use, this drug has profound effects. It can cause serious life-threatening bleeds, even more so than any of the other drugs we've talked about. So this drug, for that reason, this drug is only used in very serious acute situations. A patient with an acute MI who's at risk of dying, a patient with an acute ischemic stroke, a patient with an acute massive PE. Again, these patients are at risk for serious morbidity and more likely mortality because of those conditions. And even though this drug class carries a very high risk of bleeding, the risk of bleeding is outweighed by the risk of mortality, morbidity and mortality from the acute condition that they're experiencing. One thing to note is timely intervention is essential. The use of these drugs in these conditions has been studied extensively, and usually for the drugs to be effective, they need to be given within 90 minutes of onset of symptoms to be most effective. They can be given, up to, many hours later, but the quicker they're given, the better the outcomes with these medications. These drugs are all given intravenously, and they have very short half-lives. The half-life of Alteplase is just 5 minutes, so because of that, it's going to be given by a continuous infusion. Adverse effects, bleeding is by far the biggest concern, and the type of bleed we get most concerned with is intracranial hemorrhage. So if bleeding does occur with these medications, they need to be immediately discontinued. The patient will be transfused with either packed red blood cells or FFP, fresh frozen plasma. There is a reversal agent available, but it really is only used in very severe situations. That medication is called aminocaproic acid. Brand name is Amicar. Individual variation. I kind of regret not making this an entire slide of its own. And the reason why I regret that is because the most important thing about this drug is patient selection. Because if you don't use this in the right patient, or let me restate that, if you use this drug in the wrong patient, they're probably not going to make it. And that's because the risk of bleeding is so severe with this drug. So you have to evaluate absolute and relative contraindications before this drug is given. Now, the good thing about thrombolytics is that their use is very tightly controlled. So for you guys, for the most part, there's gonna be a team decision on when to use this medication. When I say team, I don't mean the person prescribing it. I mean the person prescribing it, all the way up usually to the attending level. The pharmacist that's going to dispense it is a part of that discussion. The nurse that's administering it, all of this group, everyone's coming together, kind of discussing, are we doing the right thing here? Because these drugs can be so deadly. So I want you guys to look at the table in your book on page 50. Actually, I don't know what page it's on, but it's table 5210. It's in chapter 52. It's probably about 3/4 of the way through the chapter. Definitely take a look at that. I'm not saying you have to memorize this list, but what I want you to do is just recognize it, because if you ever work in a setting where you potentially see patients with acute PE or acute MI, or any of the other conditions that this drug can be used for, I want you to kind of have in the back of your mind, oh yeah, there are absolute and relative contraindications to using this drug, and we've got to take a look at this before we give it. So some nursing implications: identifying your high-risk patients, and you would do that through evaluation of the absolute and relative contraindications. And then, of course, taking measures to reduce bleeding risk. So things that as a nurse you can do: minimizing manipulation of the patient, because kind of moving them around can increase their risk of being injured and potentially bleeding. Avoiding sub-Q and IM injections, again, very important to minimize the risk of bleeding. Other things: avoiding invasive procedures. Not that you guys will necessarily be performing invasive procedures, but advocating for your patient if you know they've gotten this medication or they're getting this medication. Advocating for them not to be involved in invasive procedures, and then of course avoiding concurrent anticoagulation or antiplatelet drugs for a specified period of time, because that will also increase their risk of major bleeding. Okay, so I went through all of these measures to reduce bleeding risk on the last slide, but you can see on this slide that they are all listed out for you. I think these are important things for you to focus in on, specifically with the thrombolytics, because like I said previously, with the thrombolytics, the main thing is, number one, that you're assessing patients and making sure that patients that should not get this medication do not get it. So that's identifying those high-risk patients. And then two, if the medication is administered, as a nurse, you're taking measures to reduce that patient's bleeding risk. So all of these things that we have listed here on the slide would be measures that you would take to reduce that bleeding risk. All right, so that concludes our discussion of drugs for thromboembolic disorders. If you have questions, please post them to the discussion board. This is quite a bit of material, but all of these drugs are extremely important. Please take time and study these drugs. Not only will it serve you well for our exam, of course, but also just in your clinical practice. You will see, at a minimum, you're going to see warfarin, you're going to see dabigatran, and some of the other drugs I talked about. If you work in the inpatient setting, you're definitely going to see heparin. So you will see these drugs quite a bit in your practice as nurses, I promise. So if you have questions, please post them to the discussion board, and thank you for listening. So our first review question says, which of the laboratory results, which are all flagged as abnormal in the laboratory report, would be a priority to report to the prescriber if the patient is prescribed heparin? So look these over, think about what the most appropriate response would be. So if you said C, platelet count, 40,000 per millimeters cubed, then you're correct. Obviously that's a very low platelet count. Now, in terms of evaluating patients on heparin, it's nice to know what the baseline platelet count is because we get concerned for HIT when there's a 50% reduction. But in this case, this is a low platelet count on its own. So this would be concerning, and this patient would need to be evaluated for HIT. Furthermore, the patient is anticoagulated, and the last line of defense for these patients in terms of providing protection from bleeding are the platelets. So a platelet this low, even if the patient doesn't have HIT, would be concerning. So question number 2 asks the nurse should teach patients who are prescribed warfarin to eat consistent amounts of which of the following foods. Please select all that apply. So look this list over and think about which of these foods would be important for patients to be consistent with. So if you said B and C, you are correct. Liver and green leafy vegetables like spinach do have a high vitamin K content. And so for patients on warfarin, if patients are not consistent with their intake of these foods, this can cause fluctuations in the INR and put patients at risk for either becoming subtherapeutic or supratherapeutic. Both of those situations can be detrimental to patients who are on warfarin.